updates. So we need to look at various aspects of the urothelial cancers, and the Javelin bladder 100 trial is there, and the avelumab first line maintenance data has already come, and long-term follow-up was presented at the ASCO this year. And it is important to note this data, which is even from the Asian subgroup, the benefit was permanent, it was present, and the trial had overall survival as the primary endpoint. This was able to predict the benefit in these patients as well. And at the time of data cutoff, the patients, median follow-up was close to 38 patients with avelumab and 39.6 with VSC alone. So it is very common and very good. OS in the overall population was, you can clearly see at 3 years, 29.8% versus 36%. So there's a significant improvement in the terms of overall survival. And if we see the PFS data, again, a huge difference at 2 years, 7% versus 23%. Yes, all the subgroups are getting benefit from this treatment and best response to first line treatment. Even the patients who are getting complete response, they are getting the good amount of benefit from the treatment. And the subsequent anti-cancer treatment, if we see the patients who discontinue treatment, the patients receive PD-1 inhibitor in 53% patient of supportive care alone. So this is very important, and it is very clear. At least 53% patient in the supportive care alone group could get adjoint, could get further treatment with PD-L1 inhibitor, which is very important to be noted. So it is clear. Long-term follow-up from the data clearly states that this patients are getting a significant benefit, and OS rates at 2 years was 50%, 38%. So 12% absolute improvement at 2 years survival. This is really, really huge, and it is important. There is further data from the Asian subgroup. This is again a huge number of patients. 147 patients were from Asian subgroup, and this data is matching with the overall data. So it is very clear that these patients are also getting benefit. If we see the ARIES trial, that is first line avelumab in PD-L1, there is further data where it is definitely a phase 2 study. The median was close to 10 months. So yes, it seems that the patients who are getting avelumab in the metastatic setting as a first line treatment, where the patient are not fit to receive other treatment, it is platinum based treatment, these patients are also getting benefit. If they see the LEAP-11 data, that is pembro plus lenvatinib, with or without lenvatinib, it is found that the patients does not seem to receive a very high activity. The activity is not changing, and it is somewhat similar to pembro alone. So the data for this is also released recently. This is a trophy study, sacituzumab govitecan, which is now an approved drug in triple negative breast cancer. It has also shown some benefit in metastatic urothelial cancer, and this data is clearly showing that patients are having some responses. If you see, around 60 to 70% patients have some reduction in the tumor size. So this is important for our patients who are progressing fast. And primary endpoint of PathCR, around 36% patients are having PathCR with neoadjuvant enfortumab. So this data is very, very great data. Neoadjuvant use of a drug in patients who are cisplatin ineligible, definitely patients having 36% PathCR. This is unheard of. So enfortumab vedotin seems to be a very, very active drug, and this needs to be this will be coming to India by next year. These are the various other data. With this, I would like to stop here. Thank you for the patient listening. If there are any questions or comment, that can be taken. Yes, Dr. Amit. So we have discussed the ASCO updates, where we have seen the benefit, sustained benefit of long-term control of with avelumab Javelin bladder 100 data, and also we have seen the Asian subgroup data, and also we have seen the neoadjuvant enfortumab vedotin. The neoadjuvant enfortumab vedotin is it seems to be very, very promising drug in neoadjuvant setting where patients are cisplatin ineligible. In cisplatin eligible patients, a drug is able to achieve at least 40% PathCR rates and tumor downstaging in 70% patients. That has been unheard of in cisplatin ineligible subgroups. So enfortumab vedotin seems to be very active, and especially the main point is that it is a targeted treatment. But why it is acting in all the patients, nearly all the patients? Because it is acting on Nectin-4 subgroup, Nectin-4 receptor, which is present in virtually all the patients. More than 95% patients of the urothelial bladder cancer express Nectin-4. So this is very, very important. And this drug seems to be the game changer in cisplatin ineligible patients. Neoadjuvant immunotherapy, this is also somewhat exciting approach, but the response rates are to the tune of 20 to 25%. But main important is that if we are able to combine immunotherapy in cisplatin eligible fit patients, pembro plus immuno or atezo plus chemo, where Gemcis is kept as the other drug. This is definitely improving the PAT-CR rates to the tune of 50%. PAT-CR rates are around 25 to 30% with the usual Gemcis. DD-MVAC led to improving in PAT-CR rates by more 5%. And if we are able to combine immunotherapy in these patients, we are getting more than 50% PAT-CR rates. And patient who is cisplatin ineligible, enfortumab vedotin seems to be the best drug. We are going to have a trial of enfortumab vedotin by this year end or early part of the next year. TMH Varanasi will be the leading site for the India for enfortumab vedotin.
So just for the information, enfortumab vedotin, it's basically now it's the time for the genomic landscape of bladder cancer. So depending on the genomic landscape, we see the PAT-CR rate is now varying. So it's basically seen in the patients who are, we say that the tumors are non-inflamed. In those group of tumors, it is going to FGFR inhibitors are found to be present. And there, enfortumab vedotin is having a much better response as compared to those where the tumors are inflamed. And in this group of patients, immunotherapy is somehow not working. Basically, there are two studies now. One is of a single agent of this, and the other is in combination with immunotherapy, which is, I think, so from the China, which is showing a good PAT-CR. But a single agent is also showing a response rate of something around 40 to 50%. As I already told you. So really, so it's much more now, it is becoming precise which patient is going to respond more. And this thing also happens in chemotherapy also. So just like a neoadjuvant chemotherapy, if we have having a molecular landscape of the patient, basically the genetic landscape, depending on that, you can say that this patient is going to respond to chemotherapy and have a good PAT-CR. Otherwise, in few patients, those who are resistant have got a different clone from very beginning. So might be, but we are still not doing genetic landscapes at present in clinical practice. Within near future, we will be having all these things. I think so. So just
thank you, Dr. for your comments. I think we can close here.
Sure. Okay then.
Thanks.